Is for my LSSU medical terminology class. The body system I chose for this video is the nervous system. And the three diseases that I chose for my video and my articles were Huntington's disease, Parkinson's disease, and narcolepsy with cataplexy. And the reason I chose these articles is because I actually find neurology fascinating. The study of the brain really interests me. And on top of that fact, I am part of the 0.02% of adults worldwide that has actually been diagnosed with narcolepsy with cataplexy. So I thought it'd be a great opportunity to learn more about the disease that I actually have. So I'll jump right into this with Parkinson's disease first. And where's my mouse? There it is. Perfect. Parkinson's disease is a progressive neurological disorder characterized by a large number of motor and non-motor features that can impact function to a variable degree. There is no definitive test for the diagnosis of Parkinson's disease, so the diagnosis must be based on several clinical criteria, such as resting tremors, bradykinesia, rigidity, and loss of reflexes. These are considered the cardinal signs of Parkinson's disease. However, the specific presence and presentation of these features are used to differentiate Parkinson's disease from related Parkinsonian disorders. So I'll give you a little bit more information on those symptoms. I'll start with bradykinesia. Bradykinesia refers to the slowness of movement and is the most characteristic clinical feature of PD, although it may be seen in other disorders, including depression. Bradykinesia is the hallmark, and it encompasses difficulty with planning, initiating, and executing movements. Its initial manifestation is often the slowness in performing activities of daily living and slow movement and reaction times. Other manifestations of bradykinesia include loss of spontaneous movements, so impaired swallowing, loss of facial expression, decreased blinking, less arm swing while walking, drooling, things of that nature. Next, I'll talk about tremors. Resting tremors is the most common and easily recognized symptom of Parkinson's disease. Tremors are typically unilateral and occur at the frequency between 6 and 4 hertz, and is almost always prominent in the distal part of an extremity. Hand tremors are typically the most common. However, resting tremors in patients with PD can also involve the lips, chin, jaw, and legs. But unlike essential tremors, rarely involve the head or neck or voice. Characteristically, they disappear with action or during sleep. Finally, we'll talk about rigidity. Rigidity is characterized by increased resistance, usually accompanied by the cogwheel phenomenon, particularly when associated with an underlying tremor present throughout the range of passive movement of a limb, such as flexation, extension, and rotation about a joint, and may occur proximally on the neck, shoulders, and hips, and distally in the wrists and ankles. Rigidity can also be associated with painful shoulders, and that is actually one of the most common. And real quick, I'll just give you some of the non-motor symptoms, just to give you more of an idea of Parkinson's. I'm not going to go super in-depth in these like I did with the previous ones, just because I want to move on to Huntington's and then narcolepsy. So some of these are actually pretty common with PD, and these include cognitive and neurobehavioral disorders, sensory and sleep abnormalities, and autonomic dysfunction. All right, now let's move on to Huntington's disease. Huntington's disease is a progressive neurodegenerative disorder, typically onset. The symptoms is in the middle age. Typically, the onset of symptoms is in middle-aged individuals after they have had children. That was a hard sentence. But it can manifest itself anytime between infancy and old age. Some of the more common symptoms include apathy or lack of initiative, dysphoria, irritability, agitation, or poor self-care, poor judgment, and inflexibility. The more frequent symptoms occur in about 20 to 50% of patients, and those are disinhibition, depressed mood, euphoria, aggression. And some of the more infrequent symptoms, which occur in about 5 to 12% of individuals, are delusions and compulsions. The rare symptoms, which occur in less than 5%, would be hypersexuality and hallucinations. Unfortunately, unlike the last article, this article didn't give me as much in the way of in-depth explanations on the symptoms and how they pertain to the disease. So I'm kind of focus on diagnosis and treatment a little bit. An early survey suggested that fewer than 5% at risk of having Huntington's actually get tested for it. And testing for the disorder is unfortunately not without risk, because some individuals do actually commit suicide after a positive result due to misinformation of the nature of Huntington's disease. And because of that fact, protocols are actually in place and designed to exclude testing for children or those with suicidal ideations. So in the pre-diagnostic phase, which is, pre-diagnosis, individuals might become irritable or disinhibited with work, unreliable at work, multitasking will become difficult, and they may experience forgetfulness. Anxiety may start to mount, and friends and family will probably notice restlessness and fidgeting. Partners could be kept up at night, and eventually this stage merges with the diagnostic phase, during which time they actually detect the disease. And typical diagnosis is actually from genetic testing. Huntington's disease does have some cognitive dysfunction that goes along with it. It does spare your long-term memory. However, it can impair functions such as organizing, planning, and checking, or knowing how to adapt to alternative solutions to problems. Depression is typical, and suicide is about 5 to 10 times more typical than with the general population. I need a drink. Right. So depression is typical, and suicide is about 5 to 10 times more typical than with the general population. Now, like other chronic diseases, managing Huntington's disease requires an appreciation of the limitations of medical management. Despite the advances in the medical field in the last 20 years, treatment has made little progress. And the survival rate of individuals with Huntington's disease is similar, regardless of whether or not medical treatment is available, readily available versus not readily available. Counseling can be helpful for patients and their spouses, and corrective drugs such as terabenzine or neuroleptics offer patients with severe symptoms some respite from their constant involuntary movements. However, declining function is not an indication for an increase of these drugs, because these drugs can actually cause bradykinesia, rigidity, depression, or sedation. So the side effects are there. Finally, let's move on to the one that is the most significant to me, which is narcolepsy with cataplexy. Now, narcolepsy with cataplexy is a neurological sleep disorder affecting 0.02% of adults worldwide. It is characterized by extreme daytime sleepiness and sudden loss of muscle tone, which is also called cataplexy. It can be also associated with sleep onset or sleep offset paralysis and hallucinations. Now, that doesn't mean I just have hallucinations throughout the day. It means that when I'm actually in a sleep paralysis episode, you can hallucinate. very vividly, and they are terrifying. However, it's something that is incredibly infrequent, thank God. However, it is a symptom. Other symptoms include frequent movement and awakening during sleep, and weight gain, which I can't say I've experienced. I'm skinny as a rail. However, the constant waking and movement during sleep, I can say that I've experienced a lot. It's very rare that I'll sleep soundly throughout a night. So let's move on to one of the symptoms. We'll start with cataplexy. Cataplexy is your flagship symptom. And once my particular doctor noted that I was having cataplexy episodes, he immediately sent me off for a sleep test specific to narcolepsy. And cataplexy is defined as the sudden loss of muscle tone triggered by emotional factors. It's typically positive emotions, such as laughter, pleasant surprise, or by anger, which isn't exactly a positive emotion, but anger can trigger it. It's typically not caused by fear, stress, or physical effort. Cataplexy attacks are sometimes limited to facial muscles or the arms or legs. They can also be, a jaw tremor, jaw dropping of objects, the unlocking of the knees, which is the one that I particularly notice. It's kind of fascinating that the face muscles can be affected by this. I didn't know that. So that's something cool that I learned that, maybe I should look out for. And they typically only last a few seconds, and cataplexy becomes more exacerbated with how poor your sleep is, or let me explain this better. Very, very typically, it only occurs when you've had poor sleep or you're completely fatigued. It isn't something that just happens every day. They're pretty rare occurrences. So most of the symptoms with narcolepsy are rare occurrences, aside from our next symptom, which would be daytime sleepiness. Now, this is the Hollywood symptom that everybody jumps on immediately when they find out that I have narcolepsy. They ask, so you just fall asleep? And that's not the case. It's nothing like they portray in Hollywood. It's not, I'll just be sitting here, and it's not how it works. Typically, in most cases, excessive daytime sleepiness is the first symptom to appear, which would be true for me as well. I didn't notice it right off the bat because I was working 12-hour days at the time, so I thought it was just me being overexhausted from work. Turns out that paired with my cataplexy, and then my sleep study proved that to be false. Now, typically, according to this article, it's reoccurring every 2 hours, although this can vary widely. Sleepiness is exacerbated when you are physically inactive. So, say, watching TV, sitting on a couch, reading a book, you can increase your chance to have, a sleep attack is typically what I call it. That's what my doctor calls it anyway. It's the irresistible urge to sleep. And if you ever want to know what that's like, stay up for 24 hours. And that absolute feeling of I need to sleep now is similar. But I've experienced, waking up from 6 hours of sleep or, 8 hours of sleep. Now, mind you, not all the way through. But I've experienced a sleep attack after I woke up. You wake up, got out of bed, showered, got ready for the day, and I'm like, oh, I need to sit down and go to sleep. Typically, where was I? I lost my place. Typically, the duration is pretty short in length, about 5 to 10 minutes. And if, like I said before, if you're doing something passive like watching TV, the duration can increase. But if you're out and about, doing something physical, you can actually reduce the time that it lasts and, not fall asleep during it. However, if you do fall asleep during a sleep attack, you just take it. It basically makes you take a short nap. You wake up fully awake. You feeling normal. It's fantastic afterwards. It really is. The next symptom I'll talk about is sleep paralysis. Sleep paralysis is defined as the inability to move your limbs, head, or speak or breathe normally, either at sleep onset or upon awakening, mainly from REM sleep. And that particular line is very important, mainly from REM sleep. Narcoleptics typically enter REM sleep very quickly. I believe the typical adult goes into REM sleep within an hour, and based on my sleep studies, I was going into REM sleep anywhere between 30 seconds and 5 minutes. So that's very important because of the fact that narcoleptics do go into REM sleep very quickly. We have this unfortunate symptom where you can't move your body, you're mentally aware, but your brain's still kind of in REM sleep, if that makes sense. So that's where the hallucinations come from. It isn't, you just hallucinate all day. It's a very specific situation that occurs. They're typically very terrifying, and it's not fun. Another symptom is automatic behavior, and automatic behavior is the continuation of an activity without memory of the event. In such cases, you may say something inappropriate or out of context in a conversation, write something inappropriate or not legible, and I've actually experienced that as well. I'm writing notes in class, just kind of droning on, look down, and it's just scribbles. You're like, well, that was neat. And finally, we'll move on to treatment. Now, this is a big part for me because this is how I make my disease not so debilitating. There is no cure for narcolepsy, unfortunately, so I am stuck with this disease for life, which is what it is. I mean, honestly, as long as you manage your symptoms and, are cognizant of everything that it includes, it's not debilitating. So the management of my disease relies on symptomatic therapies such as stimulants for daytime sleepiness and sleep attacks, antidepressants for cataplexy and other REM-associated symptoms, and hypnotics for disturbed nighttime sleepiness. There's only one single drug known for effective control of all three, and that would be sodium oxybate, also known as Xyrem, and it actually does work very fantastically. Xyrem is not without its side effects, however. Xyrem or sodium oxybate, when you get this medicine, you actually have to see a very specific doctor who is registered with the only pharmacy in the U.S. that makes this drug, which is a pain in the ass because those doctors are very, very busy typically. And you have to sign a waiver when you get the medicine that acknowledges that you understand the side effects and that you understand this medication can actually kill you, because you just stop breathing when you are asleep, which is terrifying, which is why I got off of it. Other drugs you can use are some such as modafinil, which is a wakeful promoting substance. Although the mechanisms and actions of this drug are not clear, the drug is recommended as the first-line therapy simply because it's, kind of the catch-all. Hey, you feeling excessively sleepy during the day, take a stimulant. current research is actually dedicated on finding new treatments to better understand the role of hypocretin. So hopefully, they will figure something out and we'll get better treatment other than take a stimulant, take an antidepressant, take, this, take that. Maybe it'll be something that they understand how it works. Currently, modafinil is the way to go for first-line treatment, which is unfortunate because I wish they had some, better understanding of how it works and what they can do to fix it, or, make it at least a little bit more manageable. So in conclusion, guys, I hope you learned something about all three of these diseases. I certainly learned a lot more about narcolepsy that I didn't know, thanks to this article. And I hope you guys have a good day.